A 56-year-old man comes to the office due to episode of transient right eye blindness that lasted an hour. He has had no weakness in his extremities or speech changes. He last saw a physician 3 years ago. The patient has smoked a pack of cigarettes daily for 30 years. Temperature is good, blood pressure is high, pulse is good. Respiration 14 by minutes. Good. Pulse oximetry is good. BMI a little bit elevate but good. There is no carotid bruit. Facial plethora is present, meaning the face is red. Cardiopulmonary examination is normal. Abdominal examination reveals splenomegaly. There is no lower extremity edema and peripheral pulses are intact. So before we go to the lab and go to the answer, we should put everything together and we should eliminate that distraction and focus on the keyword for the patient. Okay, so let's be focused. We have transient right eye blindness and what and lasted an hour, so he that is gone, not blindness for until now, just 1 hour and go. He has no weakness, no problem, so meaning there is no stroke. When he mentioned he has no weakness, so he is not doesn't have any stroke in the head, because when the stroke first happen in one place and go to another place by the loss of brain function. Okay, so when he mentioned this to eliminate the stroke. Last saw a physician 3 years ago, meanings there is no lab, no any let's see, someone check on him or any problem. That's so no, there is no care since 3 years ago. The patient has smoked pack of cigarettes daily. This is bad prognosis. No temperature, high PP. So we have transient blindness and elevate high blood pressure. Oximetry is good. No carotid bruit, meaning there is no like the cholesterol that in the carotid, meaning the stenosis of carotid because of the cholesterol and something like that, so no problem. Facial plethora is very important things, meaning the RBC is high. 99% of facial plethora there is elevate of RBC. Cardiopulmonary examination is good. No, just we have splenomegaly, okay, and no edema, meaning there is no problem in renal or in the kidney. There is everything is good. Peripheral pulses are intact. Okay, so let's move to the lab. Hemoglobin 20, hematocrit 60, elevate, platelets some kind of elevate, but it's good. Leukocyte good, sodium good, potassium no problem in the kidney as we spoke. Glucose is good. So in addition, counseling about smoking cessation, which of the following is the best therapy for this patient? Okay, the problem is just elevate of RBC and because of smoking for 30 years. Okay, another cause of elevate of RBC. Could anyone help us by speaking or type it on the call message? Please. Elevate RBC causes or high hemoglobin or high hematocrit. Yes, PV, polycythemia vera, and think about the pulmonary problems and cardio problems. If you have COPD, you have elevate RBC. If you have VSD for a long time, this will be RBC elevate. Okay, always always think about the causes of elevate RBC, not just the PV or just problem in the hematology problem. We have cardiopulmonary problem make RBC elevated. So in the fourth line, he tell us about cardiopulmonary examination is normal. So be aware of this type of questions. There is no problem in cardiopulmonary. So no wheezing, no COPD, no cough. Okay. So the problem isn't that. So what's about to do to this patient? Anticoagulation, phlebotomy, plasma exchange, prednisone, or splenectomy. Can anyone tell us? Okay, I will tell me the phlebotomy. Don't be distraction about this. If you have elevate high RBC, you have to do phlebotomy. So let's talk about polycythemia vera because we talk about there's no problem in cardiopulmonary high blood viscosity. This is cause the transient visual disturbances. Okay, elevate hypertension, erythromegalia, or meaning burning cyanosis in hands and feet, or cyanosis in the peripheral, elevated RBC turnover, meaning gouty arthritis. Okay, because RBC when they destroyed, that meaning the uric acid will be elevated, so gouty arthritis, aquagenic pruritus. Okay, meaning aquagenic, aqua meaning water. So we called aquagenic before, or sorry, after the shower. Any person had a pruritus after the shower, meaning elevated of RBC and bleeding because a lot of blood. Examination, facial plethora, splenomegaly, and as we spoke, laboratory, elevated hemoglobin. Okay, complication because of elevated RBC will stick each other and close the vascular system. So meaning thrombosis, meaning sorry, polycythemia vera may complicate to myelofibrosis or acute leukemia. Treatment, as we spoke, phlebotomy and hydroxyurea. Be careful, even if polycythemia vera cause viscosity or thrombosis or okay, viscosity or thrombosis, don't give anticoagulation. This is a trap, or sorry, trap. Please be careful. Even if elevated RBC cause thrombosis, don't give anticoagulation. Okay, the first line is phlebotomy because the reason of thrombosis is elevate of RBC, not problem in coagulate factors or problem in platelets. So don't give anticoagulation. Okay, this problem, so this is so good. And please be focused between phlebotomy and plasma exchange. Okay, when you mean what the difference between them, phlebotomy meaning just remove the blood, plasma exchange remove the blood and inject another one or another RBC or another whole blood. Okay, please be careful from these two similar answers, phlebotomy and plasma exchange. Okay, I think is everything is good. It's an easy one, just to warm up before we move to another a level higher than the previous question. Just but an easy one. Any problem? Okay. Please, if anything is happen, please tell me on the message or speak with me. Okay. We have 5-year-old boy, so it's pediatric question. Please be careful. 5-year-old boy is brought to the emergency department by his mother's boyfriend for evaluation of thigh pain. This morning, the patient bumped into the edge of a table in the living room and now has swelling and pain in the right thigh. Does anyone know what's what we should focus or what until now what we should think about? This morning, the patient bumped into the edge or something. Maybe the next or till the end of the question, we might think about hemophilia. But I need the context of this question or the meaning that we should focus on. Please, in the EMREE exam, they focus a lot of this problem. Boyfriends and thigh pain bumped into the edge of a table. This three, yes, child abuse. Very good. Please, 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 anything suspicious or make not obvious or make you not comfortable with the scenario, if with children, please think about child abuse, please. Okay, family. Until now, this is the thing we should focus on. But we'll continue. Family history is significant for maternal uncle who died after developing intracranial hemorrhage from a minor head injury last year. Okay. Examination shows uncomfortable appearing boy with marked ecomyosis and swelling over the right quadriceps. Which of the following will most likely be found on further history and examination of this patient? As the doctor or told us, we have uh, suspicious hemophilia, but what we think will be in further history: episode of joint pain and swelling, old healed rib fractures, pinpoint red spots on extremities, red papules on the trunk and lips, sister with heavy menstrual bleeding. Anyone? Yes, 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 yes. Episode of joint pain and swelling. Okay? Please be careful with this point. The five one or E, sister with heavy menstrual bleeding. It's similar that hemophilia could happen. Why we shouldn't? Sorry? Or it could happen with hemophilia. But why? Because hemophilia is rare in female. Non obvious on females because of it's X-linked. This is the first thing. And the second thing that female dies in first or in the uterus. Okay? So this is wrong by statics. Okay? Not happened. So the true is opposite of joint pain with the swelling. Let's talk about hemophilia A and B. It's X-linked recessive, delayed or prolonged bleeding after mild trauma, hemarthrosis, or intramuscular hematomas, gastrointestinal or genitourinary tract bleeding, intracranial hemorrhage, as we see in the previous history. Complications: hemophilic arthropathy, lab elevated of PTT and normal PT, absent or missing the factor 8. Okay, this is hemophilia A, or missing factor 9. This is hemophilia B. Treatment, of course, factor replacement. And for mild hemophilia, please give desmopressin. Okay, so just read the bold line: hematoma, that hemophilia. This is X-linked recessive, caused hemarthrosis, so joint pain and swelling, prolonged PTT, and decreased factor 8. Okay. What about the other answers? Posterior rib fractures. It's a red flag for child abuse. Okay. However, browsing on extremities is often unintentional, but suspicious browses include those that are patent. This is problem that make us suspicious. What the meaning of built on hand or located on the neck, ear, torso, and buttocks? This is the place could have browsing. So this is abuse, okay, or suspicious to abuse. PGA meaning pinpoint red spots. This is problem of broken capillaries and platelet disorders. Okay, but we have former history, so we didn't take this answer. Red papules meaning cutaneous arteriovenous malformation or meaning AVM. This is problem that hereditary telangiectasia. This is dominant by epistaxis and telangiectasis. This is not predisposed to skeletal muscle hematoma. The problem we have muscle hematoma. Don't forget the scenario. Heavy menstrual bleeding is common in lymphoid brand or something in platelets. Okay, but not bleeding into deep tissue. Don't forget our problem in the muscular or sorry in the skeletal muscle hematomas. This is our problem. Okay, this is another easy question just to warm up before we go to another question. Okay, 55 years old man comes to the office due to fatigue for the past month. He has also had occasional heartburn, but no chronic abdominal pain. Okay, just we have fatigue. Medical history, we have hepatomegaly. Okay, but due to fatty liver, he has been drinking alcohol per day a lot. He doesn't smoke. Physical examination reveals pallor of skin and mucous membranes and mild hepatomegaly. Okay, as we spoke, the hepatomegaly because of fatty liver. So don't think about malignancy, okay, or lymphoma or leukemia when he tell us the reason. So avoid another causes of hepatomegaly. Let's say that hemoglobin 8.5 is low, leukocyte good. MCV elevate platelets on the lower normal value. Blood glucose good, BUN and creatinine good, so no problem in the kidney. What is the most cause of anemia in this patient? We have vitamin B12, folate deficiency, chronic blood loss from peptic ulcer, anemia of chronic disease, and thiamine deficiency. Could anyone help us? When you have, sorry, folate deficiency. Okay. Let's eliminate. Okay. What we think about chronic blood loss from peptic ulcer? Why we shouldn't or why to eliminate it? Chronic blood loss. Yes, 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 yes. That's true. In the chronic blood loss, this is micro anemia, okay? But we have macro here. So eliminate. What about anemia of chronic disease? Also, the MCV will be lower than 80. Okay. Thiamine, um, thiamine deficiency, meaning a problem with neurology, problem with awareness of the people around you. What about vitamin B12 and folate? The difference between them, we will see about them, but vitamin B12 should happen with neurology symptoms. Okay, a loss of column in the posterior column of spinal cord. Okay, something like that. So the problem is folate deficiency. We have nutritional folate deficiency because of alcohol use. Just the so we have macrocytosis, MCV often higher than 110. We have mild thrombocytopenia and leukopenia. So just focus on B12 deficiency. It could cause megaplastic anemia, but we have focus with this. Although patients with heavy alcohol use can develop vitamin B12 deficiency, but nutritional folate deficiency more quickly due to smaller total body stores. So, the person to develop vitamin B12, he should be avoid vitamin B12 for 2 years. So the stores in our body cover us for 2 years. Okay. So by in addition, vitamin B12 is rare with alcohol use who don't have chronic pancreatitis. So meaning, so he need to be a lot of alcohol for too many days and too many years. So it could happen chronic pancreatitis. So to happen vitamin B12 deficiency. Okay, by the meaning or to conclude, vitamin B12 is have big stores in our body that cover us for 2 years. So it could happen with problem in stomach and small intestine that impair absorption, but not an alcohol or nutritional. Okay. Chronic blood loss, we talk about chronic anemia, thiamine deficiency, all that told about. Okay, this is another easy question. Any problem with this until now, or everything is good? Okay. Okay. Now we have this is a good question. Please focus. 25-year-old African American woman comes to the office after experiencing increasingly heavy menstrual cycles for 3 months. The patient has also noticed that her gums frequently bleed when she brushes her teeth. Review of symptoms is positive for ongoing pain and stiffness in her hands and wrists that is partially responsive to ibuprofen. She is not taking any medication and has no known medical conditions. The patient is afebrile, blood pressure is good but the systolic is elevated. Pulse is good, non-painful oral ulcer is present, and I will talk about this oral ulcer. Multiple pechiae are present on the upper arms and shins. The wrists and the hand are tender to palpation and demonstrate reduced range of motion. We have hemoglobin, platelet, leukocyte, all of three are below the normal range, and serum creatinine is elevated, which is the following is most likely cause of thrombocytopenia. Okay, is this sequestration or splenic sequestration, bone marrow invasion by malignancy, delusional cytopenia, infective hematopoiesis, or peripheral destruction? Before we talk about these answers, let's think about this woman. The positive that heavy menstrual cycles because of low platelets, this is the cause, and gums bleed also for the same reason, low platelets. But another thing that far from the platelets, pain and stiffness her hands, okay, elevate blood pressure. And what about non-painful oral ulcer? Does anyone know the cause of non-painful oral ulcer? Please, this is very important hallmark or symptoms or sorry symptom for something special. Okay. The cause of this oral ulcer that the leukocyte. Please, the leukocyte when below 400 or neutropenia. that cause oral ulcer and febrile. Okay, but not below the 1000 to cause febrile neutropenia, just a little bit that cause oral ulcer. Okay, the rest as we spoke. So, and we have elevate creatinine. So this is kidney problem or kidney failure. Okay, what's the link between these three things? The problem in the RBC and platelets and leukocytes, and problem in wrists or in the shins, and kidney failure. Does anyone have any idea? And no, no, when we have like this case and very far between them for the symptoms, please think about SLE. Please, SLE meaning the body affect himself. The body destroy a difference or different parts of the body. Okay, the keyword for SLE, woman. Okay, the three chains of blood are below the normal. Okay, and kidney failure. Okay, so the problem isn't solved until now. No, there's no solution for thrombocytopenia in this patient. Even if this patient has SLE, what the cause of thrombocytopenia? Okay, let's talk about the choices we have. What about delusional cytopenia? When this case happened, delusional cytopenia. This happened when some body take a lot of fluids, okay? When there is a history of saline or something like that. This could happen with delusional cytopenia, especially in children. When some or 4-year-old or maybe 3 or 4 months, okay, and have a fluid, this could happen to delusional cytopenia. Ineffective hematopoiesis, meaning the bone marrow isn't work good, but this is no link between infective hematopoiesis and serum creatinine. Okay, so the problem is peripheral destruction. Okay, let's talk more about this case because this is very interesting. Hematologic manifestation of SLE. We have anemia, leukopenia, thrombocytopenia. Anemia of chronic disease because this is SLE. SLE nephritis could cause a problem in the kidney, so a little bit of erythropoietin, so anemia. Iron deficiency anemia because the loss of gastrointestinal, okay, because of bleeding. Immune hemolytic anemia, the body attack the RBC, so this is immune hemolytic anemia. Leukopenia, immune mediated destruction. Thrombocytopenia, immune mediated destruction. Please, SLE meaning the body affect himself. This is the to conclude SLE. Uncommon mechanism for SLE, meaning medication, MAHA, meaning that below the table, microangiopathic autoimmune hemolytic anemia. This is the problem. Okay, plastic anemia. Okay, but the more the most common is MAHA. So this patient presentation, joint pain, oral ulcer, hypertension, pancytopenia, impaired renal function. This is SLE. Okay. The problem are include anemia resulting from immune destruction, leukopenia, and thrombocytopenia. Okay. the presence of autoantibodies. This is the most common cytopenias in SLE. But thrombocytopenia is most often caused by antiplatelet antibodies, which trigger increased destruction of platelets via immunoglobulin binding. This is the problem. Let's go to the question. Which of the following most likely cause of thrombocytopenia? So this is peripheral destruction. Okay, so the antibody affect the platelets, meaning loss of platelets. Okay, I will let you with choice A and B and D and C to read them when you study this case, but there's no problem. To conclude or to memorize SLE, clinical symptoms we have fever, fatigue, migratory arthritis, butterfly rash, serositis, thromboembolic events, neurologic hemolytic anemia, and hypocomplementemia, sorry, C3 to C4, elevate ANA and anti-double standard DNA. Okay? Okay. Everything is good. Do you need any help or something to clear it or to explain it more? If everything is good, please give me a like or any emoji that you think it's good. Okay. Thank you. Thank you. Thank you. Okay. A 19-year-old woman comes to the office due to 2 days of forced fatigue and exertional dyspnea. 4 days ago, she was diagnosed with otitis media and prescribed amoxicillin. Okay, the patient has no other significant medical history. Physical examination: soft and non-tender abdomen with mild splenomegaly. Scatar icterus is present, meaning the scleros is yellow. Okay, so this is problem of jaundice or elevate bilirubin. The remainder of the physical examination is unremarkable. Laboratory hemoglobin is low, MCV is good, MCHC is good, reticulocytes is elevated. This is a hallmark of hemolysis. The normal is 1 to 200%. Platelets is good. WBC is good. Which of the following is best next step management of these patients? So we have fatigue and amoxicillin and splenomegaly and hemolysis. So what we should do: amoxicillin discontinuation, antinuclear antibody assay, bone marrow biopsy, hemoglobin electrophoresis, liver function studies, and or splenectomy. What do you think the problem is? This is an easy question, and in the clinical life, it's very, very common, and we see it a lot in the our life. The problem is, anyone could help me with the answer? Sorry? Okay, but we have a reason. Okay, we have a prescribed amoxicillin. This is uh, let's see, the cheaper choice. Okay, I'm sorry for this answer, but the question and the exams always focus on this point about the economic way or economic field that the doctor is. In the guidelines, we should do it. We should liver function studies because of we have bilirubin. Okay, but the problem is the elevated of bilirubin because the hemolysis. So the liver is good. Okay, so the problem is amoxicillin, so we should do amoxicillin discontinuation. Okay, this is the problem, and this a very common case in our life, especially when we have a viral disease like cold or anything like that, and the people take over the counter antibodies, and we see rash and hemolysis. So this is very big problem we see. Be careful. This is as known drug-induced immune-mediated hemolytic anemia when the drug coats erythrocytes, meaning IgG binding, that cause splenic destruction of RBC. This is extravascular hemolysis, or drug triggers immune complexes or complement mediated destruction of RBC. This is intravascular hemolysis. To conclude, the RBC may the hemolyte or RBC hemolysis in the spleen, meaning extravascular, or inside the blood vessels, meaning intravascular hemolysis. What's the difference between extravascular hemolysis and intravascular hemolysis? Please focus on this point because we will explain a lot of this and answer a lot of this case. When you have extravascular hemolysis, we have splenomegaly and or hepatomegaly. Okay, this is extravascular symptom or hallmark. And we have high bilirubin when we have extravascular hemolysis. Okay, but when the intravascular hemolysis, no splenomegaly, no hepatomegaly, and no bilirubin. We have something called hemoglobinuria. Please focus. When we have intravascular, we have hemoglobinuria, not hematuria. Okay, not RBC in the blood. We have hemoglobin and not bilirubin. Hemoglobin in the blood. Okay. About manifestations, about drug-induced sudden with hours of exposure, anemia, hemolysis, meaning jaundice, dark urine, abdominal back pain. The hallmark of hemolysis is that elevated reticulocytes, meaning direct bilirubin and LDH, and lower haptoglobin. Okay, so meaning the hemoglobin is out from the RBC. This is very, very, very important information. Spherocytosis on peripheral blood smear. Please, any RBC uh, stick with antibody. For sure, the RBC turn to spherocytes. Okay, please, I will repeat it. Please focus. When we have RBC that stick with, when we have RBC stick with antibody, the RBC turn to spherocyte. So, when you see peripheral smear with spherocyte, please do something called direct COMS test, meaning that antibody is stick to the RBC and turned to the spherocyte, or this is hereditary spherocytosis, that the RBC from itself turned to spherocyte. This is a hereditary problem or genetic problem. But the something is not redundant, that when we have antibodies stick to the RBC, make it turn to spherocyte. Okay? Treatment: discontinue offending drug on transfusion. If severe of a lot of hemolysis, we should transfusion or blood transfuse. May use glucocorticoids and IVIG. Okay, but the first thing we do, discontinue offending drug. Okay, to the bold, drug-induced hemolytic anemia, splenic macrophages, extravascular lysis, or reticulocytosis, normocytic anemia, splenomegaly. We should do or that the diagnosis is made with direct antiglobulin or COMS testing. Okay, so amoxicillin should be discontinued. Okay, this is the first thing. As we spoke, DNC and DNF, I will leave it with you to study when you study this session later. Okay, this is very important question, but before we talk about, please, if you have any concern, any something, please let me know. Okay, everything is good so far. I think this is good. Okay, thank you. Okay, let's move to another case. 45-year-old woman comes to the emergency department with left leg pain and swelling that has worsened over the last 2 days. The patient has no fever, chills, dyspnea, or chest pain. And about dyspnea, please focus on this. I will be back in a few minutes. Or chest pain and has had no trauma to the left leg. Her medical history includes rheumatoid arthritis and GERD, okay, gastroesophageal reflux disease, for which he takes low-dose methotrexate, folic acid, and omeprazole, okay, because of RA and GERD. The patient has smoked a pack of cigarettes 10 days yearly and doesn't consume alcohol. Temperature is good, blood pressure is good, pulse is good, respiration good, BMI a little bit elevated. The left leg is swollen, higher than 4 centimeters compared to the right, and warm and tender on palpation. Pitting edema is present. Her legs are shown. Okay. Which of the following is the most appropriate next step of this patient? This is very, very, very important question. And almost every year comes like this question. What we should do? Aspirin, blood cultures followed by antibiotics, chest CT angiogram, compression ultrasonography, D-dimer, or embering anticoagulation. What do you think? D-dimer? Why we should you think about D-dimer? Is this DIC? When you answer by D-dimer, you may think about DIC. The no goodwill or not the patient isn't well, okay, or unwell, okay, and bleeding from anyone in the body. So this is the IC, okay, to confirm our patient is good. So nice shot, but not the true answer. Anyone? Yes, there will be the last hematology session, okay, after this on Monday, inshallah. Okay, so you have something called leg swollen and tender and warm. So this is what? It's obvious. Yes, DVT. Yes, DVT. This is DVT. So what we should do to diagnose DVT, we should do compression ultrasonography. Okay? The treatment is aspirin, but before we give aspirin, we should diagnose. Okay? We must confirm this is DVT. So we do compression ultrasonography. If this is problem DVT, we give aspirin. If the body isn't good and we have high temperature, so this is D-dimer, we should give blood cultures followed by antibiotic. Okay? This is the scenarios we should focus. What about chest CT angiogram? If he change just one word in the case, the true answer, yes, that's true. If the answer the same and everything the same, just remove the word dyspnea. So this is DVT followed by PE, and we should do chest CT angiogram, not compression ultrasonography. We should something more urgent. So this is chest CT angiogram. Please be careful from DVT and its relevant or its complications. So to be focused on answers, okay? It's an easy questions or something like that. Please focus on the on your study when you study for exam. Please be careful, not just take care about the theoretical information and the drug and etc. Please be careful with management or next step or what we should do first. Please, this is a very important question, and something like this question a lot happen in the exam. Okay. So this is modified Wells criteria for DVT, score +1 points and total score if below 1, etc. This is just read them quickly. Previously DVT, active cancer, recent embolization or bedridden, localized tenderness, swollen leg, calf swelling, etc. Okay, so DVT, we should do compression ultrasonography. Okay. Okay, let's go to another case. 45-year-old previously healthy man is brought to the emergency department due to headaches, confusion for 2 days. He has no focal weakness or sensory symptoms. So, no stroke. Please, if you have any uh, confusion, headache, and emergency, he give you some hint to know this is stroke or not. No sensory or weakness, so no stroke. The patient has no significant past medical history and doesn't take any medications. He doesn't use tobacco, alcohol, illicit drug. Temperature good, blood pressure good, pulse good, RR good. We have mild icterus is present. Okay, so this is maybe hemolysis or problem with liver. His neck supple without rigidity, so no meningitis. And another problem caused rigidity of the neck, regardless of meningitis. Does anyone know it? What the cause of neck rigidity, regardless of meningitis? Anyone know it? Okay, please write it in your notebook or memorize it. Very good. There is something called postpharyngeal abscess. Okay, postpharyngeal abscess could cause neck rigidity. Not all neck rigidity meaning meningitis. Cardiopulmonary and abdominal examinations are normal. Neurologic examination, no focal deficits. So just to highlight the keyword, headache, confusion 2 days. Okay? And no other problem. Just this. Hemoglobin, low. Platelets, low. Leukocyte, good. PUN, elevate. Creatinine, elevate. And calcium, a little bit elevate. And glucose, good. We do peripheral blood smear. So we have fragmented RBC, which meaning cystocyte. Okay, the destruction of RBC. Okay, this is the problem that causes icterus because it's hemolysis, but in mechanical way. Do you know what I do, or do you understand what I speak about? I will repeat. The hemolysis, it could be immune, the antibody attack the RBC, or it could be mechanical, by meaning a very, very little space that RBC get through and distract or distraction pathology for the hemolysis. So we have fragmented RBC, the prothrombin time normal, so no problem in coagulation factor. Which of the or meaning no DIC? Okay, when we have DIC, we have coagulations, so we have a little space and the RBC made fragmented. Okay, but when we have prothrombin times normal, so no DIC. Which of the following is the most appropriate next step in the management of this patient? Okay, let's be careful. We have focus. We have kidney failure because BUN is elevated and creatinine is elevated, and we have low platelets, and we have hemoglobin below the normal or hemolysis. These three things, he focused. These three things: low hemoglobin, low platelets, kidney failure, and the fragmented. This is a hallmark of disease called, yes, that's true, for HUS hemolysis, uremic syndrome. Okay? These three things: kidney failure, low hemoglobin, platelets. But wait, we have another two things. One is confusion and headache, and another one is the high temperature or a little bit low, high. So if this patient have just, or sorry, has had just the three symptoms: low hemoglobin, low platelets, and kidney failure, this is HUS. But we have plus these three symptoms, we have high temperature and we have confusion. So this is TTP. Okay, okay. Please memorize this penta things, or these five things. I will repeat for the last time. Please focus. This is hallmark of TTP. We'll speak about it later. Hemoglobin is low, platelets is low, kidney failure and fever and confusion. This is TTP. So what we should do when we have TTP, between them: cyproprecipitate infusion, hemodialysis, MRI, packed RBC, plasma exchange, platelet transfusion, urine during screen, whole blood transfusion. The true for the management of TTP is plasma exchange. Okay, please. This problem is happen with a lot of students. You have a low platelets. Okay, if you transfuse platelets to this patient, you will kill him. Literally. What? Please repeat. If you have TTP and or HUS and the platelets is low and you give him platelets, you killed him, because you could make this transfused platelets. When you bring it to the patient body, it could stick with each other, or agglutination with each other in somewhere in the brain, and make the brain infraction or stroke in the brain. Please be careful from this point. Even if the platelet is even if there's 10 thousandths, Don't platelet transfusion. This is bad answer. Please. If you chose this, that meaning that you are none or not safe doctor. Okay? So this is TTP, thrombotic thrombocytopenia or cytopenic purpura. This is Adam TS13 level, meaning uncleaved VWF or von Brown, so platelet trapping activation, or it could be acquired or hereditary. This is the pathophysiology. We don't need to focus on this point. Uh, the important, this is clinical features. Let's repeat the five things: hemolytic anemia, and schistocyte, thrombocytopenia, but normal beta and BTT, renal failure, neurologic manifestations, and fever. Management, plasma exchange or glucocorticoid or rituximab. Okay? The first line is plasma exchange. What the difference between plasma exchange and phlebotomy? That meaning plasma exchange, remove the old one and transfuse another or another whole blood. Okay, but the plasma exchange is important in TTP. Okay, no is special. We should focus on TTP is a life-threatening disorder. Even if you have like this question, but the answer could be different by meaning what to do, to tell him to take glucocorticoid and come back with 2 days, or give him glucocorticoid or something like that. The most important things or to do is referral to ICU. Okay, this is life-threatening condition because we have neurological symptoms. So this is urgent case. You have to referral it to ICU, not do it in your by yourself. Okay, this is important key point. Okay, the other problem is TTP is closely related to HUS. Both cause hemolytic and thrombocytopenia. Unlike TTP, HUS could happen with E. coli. So you have diarrhea previously, but neurologic finding and fever uncommon. Okay, about the answers, it's easy, no problem. Just focus on urgent case. Okay, before we talk about the last question, and as I mentioned before, the 3 session of hematology will be more than enough for your exam. Okay, and we talk about blood smear and MCV. The next session will be focused on coagulation. Okay, we'll talk a lot of platelets, talk about RBC, okay, and malignancy in the first section or first lecture. The next we will talk about coagulate and related disorders. Okay. So before we start the last question, any problem or anything you need to know? Okay, you are welcome. Thank you. Okay. A 15-year-old man comes to the office due to feeling fatigued and weak for a year. He becomes tired early in the day and also finds it difficult to remember things. When you have hematology problem and neurology problem, please be careful. Okay, the link between these two systems is very important. Okay, difficult remember things. Sorry, sorry. Okay, okay. So The patient says he is drink 2 3 beers a day. This is the problem. Charge has been charged multiple times with driving under the influence, so he is alcoholic. His parents died of old age, so no history. He lives with 4 friends. Vital signs normal. Leukocyte good. Hemoglobin below the normal. Platelet good. RBC a little, so very below the normal. MCV is high. MCH good. Reticulocyte is good, so no hemolysis. Okay. We have a low hemoglobin and MCV is low. Peripheral smear anisocytosis. What's the meaning of anisocytosis? Meaning the RBC not in the same size. Anisocytosis. Okay. Poikilocytosis, it's not important things. Basophilic stippling happen in two things. Okay, or the most two common causes of basophilic stippling, meaning the RBC have basophilic, they like point in the RBC and the smear, happen in two things: blood lead levels, and we will see the other cause. What to do in the next step in this patient? Blood lead levels. But why this is wrong answer? Because blood lead levels make MCV below than 80. Okay? So MCV will be microcytosis. Bone marrow biopsy, if you have a malignancy or risk factor, you should do bone marrow biopsy. But we don't have any hepatomegaly, any white loss, intentionally, any any fever, so there is no problem make to do bone marrow biopsy. Direct antiglobulin, that meaning comps. Don't do comps because we don't have reticulocytes elevated. Okay, so it's not hemolysis problem. Iron studies, it's MCV below 80, serum B12 and folate levels. This is the right answers. Okay, we should do serum B12 and folate level because a nutritional problem. I just want to conclude our session with two table important, or sorry, until now this the final one. Common cause of macrocytic anemia, just to remember it: folate deficiency, vitamin B12, myelodysplastic syndromes. Please be careful from these disorders when you have a problem in the bone marrow. AML, drug-induced liver disease, alcohol abuse, hypothyroidism. Even if the problem is alcohol, but we should do B12 and folate deficiency because a nutritional deficiency. Okay? Until now, everything is good. We have macrocytic anemia, so it's megaplastic. Okay? MCV higher than 100. Or we have non-megaplastic, this problem: alcohol, hypothyroidism, drugs, and liver disease. We should do B12 and folate levels. Okay. Lead poisoning could happen with basophilic, but MCV below 80. Bone marrow to diagnose myelodysplasia. Okay. We don't do it first. We should reserve for evaluating patients with normal B12 and folate levels. If the B12 and folate is good and no problem, we should do bone marrow biopsy. Comps, no, don't do it. Iron, don't do it because because iron need to microcytic anemia, and we don't have it. Okay, we'll stop here to the next session to end the hematology, and please to check that hematology is more than enough. After the next session, please go to the past paper and you will see you will solve good. and have a good idea. And there is no problem at all because we focus on blood smear. This is the most important pictures in the hematology section. Okay. Until now, if, is everything is good? You're welcome. Any WhatsApp group on EMREE, they have the previous space papers. If you don't see it, please text me. I will send it to you. I'll send the previous. I don't have the last year space paper. Okay, because it's very hard to remember the question because it was very hard. I'm sorry to tell you this, but this is the truth. But I think we will do good. Best of luck for you all. We will see you on Monday, okay, to end of hematology. Thank you very much. I hope you see this beneficial to you. Until the next time.